So number 29. Note a feature of myocardial infarction. So you can attempt in the chat. Which one is not a feature of myocardial infarction? The answers in the chat. A scar on the mural wall of the atrium confirms old infarcts. That is true. Microscopy shows coliquative necrosis of myocardium in acute infarction. So we leave that. Acute infarction is not readily recognized grossly. That is true. Hypotension may lead to infarction in a previously stable coronary artery disease. True. Infarction of the conducting apparatus may lead to arrhythmias. Yes. So for choice B, microscopy shows coliquative necrosis of myocardium in acute infarction. This is not true. Which type of necrosis do we expect in an MI? Is it liquefactive or coagulative? So liquefactive necrosis, okay, how I usually remember is coagulative necrosis. It is a characteristic of ischemic infarction of any organ except the brain, okay? Except the brain. So all the other organs, you know, the lungs, liver, spleen, all the other organs you can mention, the kidney, undergo coagulative necrosis except the brain, which undergoes liquefactive necrosis. Okay. Yeah, so I hope this one is clear. Yes, liquefactive brain. This one I think we had already done, but a 55-year-old female is found to have an occult blood in her annual exam. A colonoscopy reveals a solitary 1.5 centimeter rounded erythematous polyp on a 0.5 stalk in the descending colon. The histological examination is most likely to reveal it is so this is look at the stalk, this is a adenomatous polyp. This one I think we had already done. Yes. And then this one, a 45-year-old male had a darkly pigmented lesion at the back of the right hand that after biopsy is reported to be malignant melanoma, which is a risk factor. This one is an easy question. So malignant melanoma, the risk factor is ultraviolet radiation. Yes. Yeah, so come here. Okay. A 42-year-old female presents with abdominal pain and bloody diarrhea that is negative for ova and parasites. The symptoms continue for 2 weeks and she begins to feel better without treatment. She has had several episodes over the last 10 years. Colonoscopy reveals diffuse superficial ulceration of rectum to ascending colon. So this already gives out. What condition is this 42-year-old female presenting with? So first of all, before we answer the question, what condition is this? Yes, ulcerative colitis. Bloody diarrhea, abdominal cramps, and the colonoscopy reveals diffuse superficial ulceration of rectum to ascending colon. Then this patient is high risk of developing. So maybe I can go through UC because it's a very high yield topic for UC. So for UC, we have inflammatory bowel diseases divided into two. There's ulcerative colitis and there's Crohn's. Ulcerative colitis, the main presentation that will distinguish it from Crohn's is bloody diarrhea, okay? So it's usually bloody diarrhea with, it can be with mucus or mucoid, okay? So we have bloody diarrhea, and then we have the abdominal pain or abdominal cramps, as in this lady. Then we have the urgency to pass stool, or can I say fecal urgency. And then we have tenesmus. We have tenesmus. So tenesmus is the fact that you're distressed, you want to go to the toilet, but when you go to the toilet, you have an empty rectum, so you don't pass any stool. So that is tenesmus. Yes, and if so those are the intestinal symptoms. For the extraintestinal symptoms, what do we expect? This one they usually ask. So I can classify them based on where it is associated. So for example, in the skeletal, we'll expect osteoarthritis, ankylosing spondylitis, and sacroiliitis. So basically inflammation of the sacroiliac joint. Those are the three skeletal. For ocular, uveitis or inflammation of the uvea, episcleritis, and iritis, inflammation of the iris. And then we have primary. So for the biliary system, we have primary biliary cholangitis. Okay. The classic presentation of a patient with a primary sclerosing cholangitis is usually a male who has a history of UC. Okay. And then for the cutaneous, we have erythema nodosum, pyoderma gangrenosum, apothos stomatitis, physostomatitis, vegetans, there are quite a lot. But you have to remember, extraintestinal manifestations are most common in ulcerative colitis. That's the most important thing you have to know. Okay. Sorry for the notification. And then another high thing about ulcerative colitis is histological findings. This one you have to know, you must know, the crypt abscesses. Okay, so for the crypt abscesses, we also have mucosal atrophy and epithelial dysplasia. Those are the histological findings you expect. And for complications, now what the question is asking, this patient is at high risk of developing. We have increased risk of colorectal cancer, specifically adenocarcinoma of the colon. So choice A is the answer. So we can look at the other choices. So let's start. Pseudomembranous colitis. What is pseudomembranous colitis? This one, you did it in the spot. Give me 3 conditions where you can develop pseudomembranous colitis. Answers in the chat. This one, Oliver had gone through it. We saw the spot. 3 conditions where you can develop pseudomembranous colitis. Yeah, so I'm seeing one is saying C. difficile. Yes. So C. difficile, overgrowth of Clostridium difficile. Another one. Another condition where you can have pseudomembranous colitis. Another one, immunosuppression, yes. So for the immunocompetent, they'll have pseudomembranous colitis. And the most important one you're forgetting, So the most important one you're forgetting is use of broad spectrum antibiotics. So these broad spectrum antibiotics will destroy the normal flora of the gut, leading to the overgrowth of Clostridium difficile. Yeah, so those are the three conditions where you develop pseudomembranous colitis. Then fat malabsorption. Fat malabsorption. So there's this question they like asking about fat malabsorption. It's a clinical chemistry question, I can tell you. So the question is, what is the most common symptom in fat malabsorption? Steatorrhea. So you'll present with steatorrhea. So steatorrhea is basically is the stool that has presence of fat. So the bile. So we know bile that breaks down fat. So maybe you have a problem with the secretion of bile or the pancreatic enzymes, and then so I think this, so primary biliary cirrhosis. So as I told you, primary biliary cirrhosis is a patient who has UC, but the question here is asking, this patient is at high risk of developing. So the answer is adenocarcinoma of the colon, but I think we can discuss primary biliary cirrhosis. We can discuss. So these are conditions that affect the biliary tract. So apart from primary biliary cirrhosis, which other two conditions do you guys know? The biliary tract pathologies. Apart from primary biliary cirrhosis. So we have, I'm seeing someone has said, so they're divided into three. Number one, primary sclerosing cholangitis. Number two, primary biliary cholangitis or primary biliary cirrhosis. And then number three, secondary biliary cirrhosis. So what's the difference? So I want you to think, these are pathologies that affect the biliary tract. So you'd get a question stem telling you maybe a 42-year-old female. One, the presentations they usually have is number one, we have pruritus. So for the pruritus, the reasoning behind it is there's deposition of bile salts in the skin. So you'll have pruritus. Number two, dark urine. Dark urine. So the urine is the conjugated bilirubin informed to produce the dark urine. And remember, when you have dark urine, it goes with the pale stools, so light colored stools. And then we have jaundice, obviously jaundice, but this type of jaundice will be, what type of jaundice will you expect in a patient with a biliary tract pathology? So is it prehepatic, hepatic, or post-hepatic jaundice? PST. So I don't know. PST can mean prehepatic or post. Yeah, so post-hepatic. It's post-hepatic or obstruction jaundice. Yes. So another thing they usually present with is hepatosplenomegaly. Okay. And then, yeah. So let me start with primary sclerosing cholangitis. So for primary sclerosing cholangitis, the high-yield thing you have to know is that there's something known as onion skin fibrosis. So this, you will be told on histology, you'll see an onion skin fibrosis. It's usually the appearance of usually see on histology. It looks like when you cut an onion into half, you can imagine the section, round, 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 and round. So that's how it usually looks. And then a beading appearance when you see in diagnostic imaging. Okay. Yes. And I told you the classic presentation is it will be a middle-aged man with ulcerative colitis. Okay. If you just see a middle-aged man who has a history of ulcerative colitis, think of primary sclerosing cholangitis. Okay. Yeah, that's the high yield thing. Then for primary biliary cholangitis or primary biliary cirrhosis, typically in females, compared to the other one that was in males. And in here, it's an autoimmune condition. What happens is the T cells go and attack the cells that line the biliary duct. Okay. So what happens is for diagnostic, you'll have antimitochondrial antibody will be positive. Okay. So that's the main thing. If they say it was positive for antimitochondrial antibody, think of primary biliary cholangitis. That's the high-end thing you have to know there. Then for secondary biliary cholangitis or cirrhosis, this is extrahepatic biliary obstruction. So what will happen is you can imagine when you have extrahepatic biliary obstruction, you increase the pressure of the ducts, leading to fibrosis or injury, isn't it? Yeah. So the difference between primary and secondary is that for secondary it is autoimmune. Sorry, for primary it is autoimmune, and secondary is obstruction. So what in secondary you won't expect to find the antimitochondrial antibody. Yes, to be positive. Okay. I know that's a lot of information, but at least I'll try to summarize it with the high yield stuff. So I hope that's okay. I think I have a picture here. I'm going to send in the group. You see the differences. But I hope for that it's clear. So unless you have a question. Yes, so we can move to the next one. Number 43, yes. Okay. A 32-year-old male has a strong family history of colon cancer. He therefore has a screening colonoscopy that finds 5 polyps in the sigmoid colon, one of which has a focus of adenocarcinoma. Which type of inherited genes are most likely involved in this tumor? So answers in the chat. Which gene do you think is involved? So I'm seeing people saying DNA mismatch repair. So this is also a very high yield topic on the pathways. Let me actually just send a picture so that it's easier when I'm explaining, so that we can follow through. I'm sending a picture on the group so that we can follow through. This topic, this pathway is very high yield. It can even come in an essay. We're told to describe the pathways. There are 2. So I've sent. You can check your WhatsApp. Okay. Have you seen? Okay, so we can go through it together. So there are two pathways in adenocarcinoma. The first one, can you see the first one? The chromosomal instability pathway is the most common. You can see it's 85%. And then the second one is the microsatellite instability pathway. So we can go through it. Don't know if I can you see? Yes. So we can go through it together. So as I said, there are two pathways. The first one is the chromosomal instability pathway, and the second one is the microsatellite stability pathway. Okay. So we start. This is the normal epithelium. Okay. So what happens is we have tumor suppressor genes, so APC. So we lose the function of this gene, or when I say lose of function, we can it can be loss of function where it doesn't work, or there is a mutation in this APC gene. So what happens is when you lose function, what happens? There is hyperproliferative epithelium here. It is results in a hyperproliferative epithelium. Basically, it's just continuous division, cell division. So you lose intracellular cell adhesion, this, and increase in cellular proliferation. Okay. I hope you've understood this part. Now, when you have hyperproliferative epithelium, where it looks like this, now you also have a mutation in the proto-oncogene, which is KRAS. This is also high yield. So remember, you lose function of the APC, leading to increase in beta-catenin, leading to decrease in intracellular adhesion and increase in proliferation. And then after that, mutation of the proto-oncogene, KRAS, results in abnormal epithelium proliferation. Can you see? So it will continue, cell division will continue until it forms a adenoma. Can you see there? Yeah. So in this process, we have, remember, cellular proliferation is not regulated here. So both cellular signaling and cellular proliferation, leading to the formation of an adenoma. Then after that, we have now loss of the tumor suppressor genes. So TP53 and DCC, as you remember, I told you, deleted in colorectal carcinoma. Remember when I was explaining DCC increases risk of colorectal carcinoma? Yes. So what happens is increases of carcinogenesis. So the adenoma will turn malignant, leading to the formation of a carcinoma. Okay. Are we clear? So this is very high yield. So the first one, chromosomal instability pathway. In familial adenomatous polyposis, in most cases of sporadic colorectal carcinoma. This is the pathway. Okay. Yes. Now let's go to this other one. Microsatellite. Oh, sorry. Microsatellite instability pathway. Okay. So we start normal epithelium. Okay. Then the epithelium affected by inherited or acquired mutation. So here you acquire a mutation of mismatch repair genes. Okay. Remember in Lynch syndrome, was it HNSPP? The Lynch syndrome. Remember, we talked about it. So here is where there's the DNA mismatch repair genes. Okay. MLH1 and MSH2. So this will result in abnormal proliferation and formation of the adenoma. But notice, look at the adenoma. This is sessile serrated. So somatic mutation resulting in a loss of function of the second allele, sessile serrated adenoma. Okay. Is that clear? Then after that, accumulation of mutations in genes involved in cell survival and proliferation. This will lead to becoming malignant. And this is the carcinoma. And this one only occurs in 15% in Lynch syndrome and some cases of sporadic colorectal carcinoma. So I hope these pathways are clear. So unless you have a question, I hope the pathways are clear. So which type of inherited genes are most likely involved in the tumor? Is it now, are you able to answer it? So DNA mismatch, repair. So which pathway is this one? Is it chromosomal instability or microsatellite instability pathway? For this question, which pathway? Microsatellite, yes, good. At least I've seen you've understood. Yeah, so remember that, go through that diagram while you add some notes. It can come in an essay, a very high yield. Okay. Next question. Yes. The joint disease that is more common in women. So answers in the chat. D, osteoarthritis. Someone is saying E, rheumatoid arthritis. Someone is saying E. Yes. Okay. Okay, so we can agree it's either D or E, isn't it? So I can eliminate. So staphylococcal arthritis. So this is basically arthritis, which is inflammation of the joints caused by staphylococcus, isn't it? Sorry. Caused by staphylococcus, isn't it? Tuberculosis, same to this, tuberculosis of the joints, as we had seen there. Then gouty arthritis, I'm sure this one you know about gout. Gouty arthritis is just joint inflammation that occurs due to gout. Okay, so gout is now the deposition of the uric acid crystals in the joints. So that one is equal. Yeah, but gout most likely males. This one is more common in males. Now, between osteoarthritis and rheumatoid arthritis. So for this, you have to know the difference first of all. Okay. So you have to know. So which one is autoimmune? Okay, not no, I would say that. Okay, which one is inflammatory and which one is non-inflammatory? Is osteoarthritis inflammatory or non-inflammatory? And is rheumatoid arthritis inflammatory or non-inflammatory? Which one is inflammatory and which one is non-inflammatory? Yes, so rheumatoid arthritis is an autoimmune and it is inflammatory. Osteoarthritis is non-inflammatory. Basically, it is due to the mechanical wear and tear of the joints. So you can imagine you're using your joint and it increases with age. The older you get, the higher chances of risk to osteoarthritis. Rheumatoid arthritis, purely inflammatory. And rheumatoid arthritis is a very high yield topic, both in anatomic pathology and immunology. I think we can go through it. So one, the etiology or the risk factors is one, being female. So actually the answer is that, female. Number two, we have HLA. Which HLA is it? Human leukocyte antigen. Which one is it? Get answers in the chat. Which HLA is will predispose you to rheumatoid arthritis? Human leukocyte antigen. DR4. Yes, good, excellent. DR4. HLA, DR4. How I usually remember, the HLAs are quite a lot. How I usually remember for rheumatoid arthritis, I usually say HLA DR4. So the 4 is for like, I usually say a 4-walled room. So RHEUM, 4-walled room. So you remember DR4. Yeah, that's how I usually remembered. Another risk factor is tobacco smoking. Another thing that they usually ask, the 2 autoantibodies that are in rheumatoid arthritis, which ones? Which 2 autoantibodies are in rheumatoid arthritis? Anti-CCP, yes. Anticyclic citrullinated peptide antibody, yes. And RF or rheumatoid factor. So rheumatoid factor. Which one is more specific between anti-CCP and rheumatoid factor? Which one is more specific? Anti-CCP, yes. Anti-CCP is more specific. Yes, compared to rheumatoid factor. The next okay, I think we can do both rheumatoid arthritis and osteoarthritis at the same time. For osteoarthritis, as I've said, is mechanical wear and tear. So it is the more you use the joint, the more you predispose to getting osteoarthritis. And predisposing factors, number 1, daily stress on weight-bearing joints. So you can have joint trauma, we've said increased age and obesity. Obese people are most likely to get osteoarthritis than those that are not obese. Okay. Yes. And remember, osteoarthritis is the most common chronic joint disease. Yes, so most people get it. Now for the presentations, let's start with rheumatoid arthritis. I'll ask. Rheumatoid arthritis. When using the joint, does this, okay. So obviously you'll have pain. Pain is a hallmark. Pain, swelling, and morning stiffness, isn't it? So does the morning stiffness last for more than 1 hour or less than 1 hour? These are when differentiating osteoarthritis and rheumatoid arthritis. Does the morning stiffness last for more than 1 hour or less than 1 hour? Any answer in the chat? So it's more than 1 hour. Yes. So for the hallmark of rheumatoid arthritis, number 1, chronic morning stiffness lasts for more than 1 hour. Question is, does it improve with the use or improves with rest for rheumatoid arthritis? Answers in the chat. So it improves with use. Excellent, excellent, excellent. So that's the hallmark of rheumatoid arthritis. Number 1, chronic morning stiffness that lasts more than 1 hour, improves with use, and is long-term, usually greater than 6 weeks. So if they ask a question, maybe, 38-year-old female comes complaining of morning stiffness lasting more than 1 hour and improving with use, think of rheumatoid arthritis. Now for osteoarthritis, morning stiffness less than 1 hour, does it improve with use or improve with rest? So this one improves with rest. You can think about it. Imagine if you have a joint that has been worn off, and you think about it. Would you want to continue wearing it off or just rest? So you'd want it to rest. So it improves with rest. But for rheumatoid arthritis, you have stiffness that is autoimmune. So you can imagine, would you want to stay rest and continue with the autoimmune reaction or improve with use? So you think about it improves with use. And then another thing to differentiate is rheumatoid arthritis has a lot of extra manifestations, extra articular manifestation, basically manifestations outside the joint. And for osteoarthritis is the systemic symptoms are not there. That's also important. Okay. Yeah. I think that's the most important thing. Yeah. I think that's the most important thing. So I hope you've understood. So I hope you've understood. I'm seeing someone is asking in the chat, rheumatoid arthritis is which type of hypersensitivity? Yeah, I remember I even asked you guys. So which one is it? So which one did you say? I'm seeing people are saying 2. Someone is saying 4. Someone is saying 3. Wow, they're varying answers in the chat. So see 2, 3, 4, you can as well say yes. So the answer is 3. So I can understand where the confusion is. We said, remember, rheumatoid arthritis and rheumatic fever are very different things, 2 different things. Okay. Rheumatic fever, where we said the hallmark of a type 2, what do you think of? I said cytotoxic. It is cytotoxic, consists of 2 components, antibodies and antigens. So this is where I told you about rheumatic fever, where we have molecular mimicry, where the body fights the is it group B streptococcus, the strep pyogens, M protein. So those M proteins are similar to the ones in the heart valve, leading to development of rheumatic fever. That is rheumatic fever, and it is type 2. But for rheumatoid arthritis, we have to involve the complement. And when you involve the complement, we have, think of type 3. And we said type 3 is antigen, antibody, and complement. So that is 3 things. So that is rheumatoid arthritis. So don't confuse. When we say rheumatoid, the word oid means like, I won't say a fake version, but a version near that. So it mimics it. Okay. So rheumatoid arthritis. So similar to Android. You see the word oid. It's like a mimicking. So I hope you've gotten so rheumatic fever is type 2. Rheumatoid arthritis is type 3. I saw someone answering type 4. For type 4, I don't know that I mentioned, but I usually remember it by remembering the 5 T's. Okay. Type 4, 5 T's. Number 1, T cell mediated, T cells. Number 2, TB skin test. So for the TB skin test, we have, it's also known as the Mantoux reaction, the Mantoux test, that is TB. The 3rd T is transplant rejection. So you find it in transplant rejection. The 4th T is touching. So touching, think of contact dermatitis. That is a type 4 reaction. So and the 5th T is T for terminal. Terminal meaning it's a delayed hypersensitivity reaction. Okay, so that's how I usually remember. 5 Ts, type 4. Type 3, antigen, antibody, complement. Okay. And you remember for type 3, one thing I've forgotten to say is immune complexes must be formed. Okay. And then for type 2, we said it's cytotoxic, where we only have the antigen and the antibody. And then for type 1 is the first one. So like it's usually IgE mediated, like for example, asthma and allergy. Yeah. So I hope I've given you a great summary. We can go to the next question. Okay. A 16-year-old boy has multiple basal cell and squamous cell carcinomas in the sun-exposed areas of his skin. His younger sister is similarly affected. The disease is most likely to result in defective genes that. So answers in the chat. C, so regulate repair of damaged DNA. Yes. So basically here, so BCC and SCC, what is the exposing risk factor? Ultraviolet radiation. So what happens to UV? As we mentioned, I'm sure we mentioned above, UV causes damage of DNA. So remember, these are the DNA in the skin cells. And what happens is the body tries to repair this damaged DNA by the ultraviolet. So you can imagine if the mechanism is has been altered with, leading to the formation of this basal cell carcinoma and squamous cell carcinoma. So basically, it's a defect in regulation of repair of the damaged DNA by the ultraviolet rays. Okay. I want to ask you a question. So, which is the most common while at skin? Which is the most common skin cancer, and which is the second one? So between basal and squamous. Let me see. Basal, I'm seeing someone saying basal most commonest, squamous most commonest. So for the answers of basal, is that the second most or the most common? So the most common is basal. Okay. The most common skin cancer. And then the next one is squamous cell carcinoma. Yes. And then another thing that I usually remember is basal cell carcinoma. I usually remember upper lip. So they are more common above the upper lip, and then squamous cell carcinoma more common below the lower lip. So this is good in sport. You can imagine if you brought a picture of maybe a spot on the lips. So if you identify if it's the upper lip, think of basal cell carcinoma, which is the most common, and then a squamous cell carcinoma, which is you'll see in the lower lip, which is the second most common. Yeah. And both of them, think of UV ultraviolet as the cause. Yes, I think, is that the last question? Oh, there's this one. This one I think we already did. A 25-year-old male has intermittent abdominal pains for several weeks. A colon biopsy reveals patchy, acute, chronic inflammatory cell infiltrate, crypt abscesses, and severe non-cacheating granulomas. So what is the answer here? So it's easy. One is Crohn's. Yes, so remember, non-cacheating granulomas, Crohn's. Yes, this one is easy. Yeah, I think it's over. So any question before we start endocrinology? I'm seeing someone is saying, what is sarcoidosis? So maybe I can touch on sarcoidosis. Choice A, what is sarcoidosis? Okay, yes. So sarcoidosis will present with non-cacheating granulomas. Yes, that's actually true. But where does sarcoidosis normally affect? Which part of the body? Which part of the body? Answer in the chat. Where does sarcoidosis normally affect? So it's in the lungs. Yes. So this is respiratory pathology for sarcoidosis. And then the most, I actually did this question when we were presenting for Anatopatho. So I actually remember. The most common etiology is blacks, and they are female. So black females are the most likely to get sarcoidosis. Okay. What I can remember from sarcoidosis, it is immune mediated, and they're non-cacheating granulomas. They affect, so you can imagine, okay, some other associations. We have Bell's palsy, uveitis, inflammation of the uvea, erythema nodosum, yes, very important, erythema nodosum, and hypercalcemia, associated with hypercalcemia, increased in calcium levels. Yes, and remember the granulomas are non-cacheating. Yeah, I don't think sarcoidosis has anything else to add. So yeah, those are the most important thing about sarcoidosis.